All right, so I wanted to share a interesting case that I had the other day. I took care of a 30-year-old woman who had a previous Fontan procedure, and we were doing a general laparoscopic case on her. And for those of you that don't know what a Fontan procedure is, these patients are typically born with either one ventricle or a underdeveloped right ventricle. And for the Fontan procedure, in the first few years of life, there's a cardiac surgery in which the venous return, so that the vena cavas are directly then connected to the pulmonary artery. So it bypasses that either absent or underdeveloped right side of the heart. And so what this means then is the driving force to get blood across the pulmonary circuit, there's no right-sided pump doing that. It all relies upon the pressure gradient of how much pressure you have returning from the venous systemic system compared to the left ventricular and diastolic pressure. So we want to make sure if we're doing a general anesthetic on these patients, we're keeping that central venous pressure elevated. So you don't want these patients hypovolemic. There can be a very dramatic drop in cardiac output then due to a lack of a preload if that happens. Secondly, if it's possible, you want to keep the patient spontaneously ventilating because positive pressure ventilation from mechanical ventilation can cause an increase in the intrathoracic cavity pressure, which would decrease the venous return. Secondly, I had to have a lot of communication with the surgeon in terms of positioning changes, the pressure from insufflation of the abdomen. That all puts pressure on the venous return and the intrathoracic cavity. So there's a lot that goes into the communication side of things, just ensuring that we have that good venous return and maximizing that pressure coming back. We opted to put in a TEE just to be able to better monitor the cardiac output and the cardiac function. And you can also choose to do invasive monitoring with a CVP as well.